Right, I think it's best to get started. It's almost 9:09. Thank you to everyone for making it on a Saturday morning. Just to start things off, I have apologies from Solange Rosa, who was down to chair this panel. Unfortunately, she's quite ill, so she couldn't make it, so she sends her sincere apologies. So you've got the backup chair of me. So I will do my best to kind of fill some very big shoes. This morning I kind of have great pleasure to welcome colleagues from the Western Cape Government and other initiatives within the Western Cape, the Safety Lab and the Cape Town Partnership, to talk about violence and violence prevention in the Western Cape and really kind of how the Western Cape Government and others are planning to tackle this. So we have 4 speakers this morning. Get my right face on the program. We have speaking first. Michael, you're going to speak first.
Yeah.
We've got Michael Cardo, who's the Director of Policy Research and Analysis within the Department of the Premier. Then we've got Gideon Morris, who's the Chief Director of Civilian Oversight in the Western Cape Department of Community Safety. We have Tracey Naledi, who's the Director of Health Impact Assessment in the Western Cape Government, and have Noah Maltz, who's Director of the Safety Lab, which is in the Cape Town Partnership. So without any further ado, I'd like to kick off. Each presenter is going to get about 15 minutes, and then we're going to open the floor for any comments or questions. This session is being recorded because I think there'll be probably a lot of interest outside of this particular forum as well. So the presenters will be making use of this little gadget too. So no further ado, Michael, if you'd like to kick off.
Thanks very much, Guy. Morning, everybody. I'm going to be talking about the Integrated Provincial Violence Prevention Policy Framework, which was adopted by our Cabinet in August of this year. And it provides the overarching policy framework for violence prevention efforts in the Western Cape Government. And it focuses on a set of key strategies for preventing violence in the province. Just to give you a bit of background and context, every year the Western Cape Government spends about 80% of its health budget alone on preventable conditions, including injury-related deaths on our roads and injuries and deaths from interpersonal violence, fueled much of it by alcohol and drug abuse. Of course, this places a massive burden on our healthcare system, and it drains precious resources away which could otherwise be spent on improving the lives of people in the province and providing healthcare to patients suffering from illnesses that aren't preventable. But of course, the costs of violence aren't borne by the state alone. Violence, as we all know, devastates families, it destroys communities, and it rips apart the social fabric. So what we in the province aim to do is to institutionalize an integrated framework for violence prevention that brings together the state and civil society, citizens in partnership, working in what we call a whole-of-society approach to violence prevention. Gideon Morris from the Department of Community Safety will speak about this whole-of-society approach with particular reference to safety, but it's something which we've broadened out to violence too. And what does this whole-of-society approach mean? Well, very broadly at a high level, it means obviously that the state has a duty to shape the kind of socio-economic environment that discourages violence from taking place in the first instance by expanding opportunities to individuals, families and communities so that they can take control of their lives, and this will hopefully reduce the risk of violence occurring in the first place. But then of course there is a role too of individuals, communities, etc. Individuals through the choices that they make, parents through the responsibility that they take and the guidance they give, and we had a great panel session yesterday on positive parenting. Whole communities through the kind of cultural and social norms that they established around attitudes to gender, for example, as well as institutions in the leadership that they provide. Some further background to this violence prevention policy framework. It really has its genesis in the 2007 Burden of Disease Reduction Project initiated by our Provincial Department of Health, which identified violence prevention as one of the key public health priorities to be included in the department's 5 focus areas, and Tracey might want to touch on that. And then a couple of years later, in 2011, the Western Cape Government actually co-hosted through its Department of Health the 5th Milestones meeting together with the World Health Organization and the National Department of Health. And I think the next Milestones meeting is actually coming up quite soon. Anyway, what Milestones 5 did was to emphasize the need for our provincial government to put in place an integrated and intersectoral framework that sets out certain key strategies for violence prevention, all backed up with evidence-based, data-driven violence prevention programs. And the first draft of this violence prevention policy framework was driven through our Injury Prevention Working Group, which is located in one of our provincial strategic objectives, what we call Provincial Strategic Objective 4 on increasing wellness. We've got 11 provincial strategic objectives in total. Each of them has a number of working groups under them, and the Injury Prevention Working Group, as I say, is located under SO4, and it's chaired by Richard Matsopoulos, who many of you will know, and who was actually the drafter of the initial version of this policy. And a lot of this document is based on the work of Richard and his colleagues at the MRC. And the final version of the policy was adopted in August this year. Many of these facts and figures a lot of you will know. About violence globally, it claims 1.6 million lives annually worldwide, which equates to around 4,000 deaths a day, 50% by suicide, more than 1/3 die by homicide, and roughly 10% die as a result of war or some other form of collective violence. Around 90% of deaths are due to violence occur in low-income and middle-income countries, and males account for around 77% of all homicides. Violence in the Western Cape, and a lot of this is based on work done by Richard Matsopoulos and Tracey Naledi in our provincial injury mortality surveillance survey, which comes out twice a year. The figures for 2010, which are the latest that we have thanks to that survey, there were just over 9,000 deaths recorded in the Western Cape catchment area during the course of that year, January to December. Some 60% of those deaths, just under 5,500, were due to non-natural causes, and the highest proportion of those non-natural deaths were due to homicide, 41% of the total, and also quite significantly road deaths, 28% of the total. Violence accounts for around 13% of premature mortality. It's the second leading cause of years of life lost after HIV/AIDS. So we know Western Cape mortality rates, it was mentioned by Dr. Lawrence yesterday, they are higher than our national rates for males, and per 100,000, 129 versus 115, as well as for females, 25 versus 21. 15% higher in this province than other provinces, and interpersonal violence is the second leading cause of premature death in the province after HIV/AIDS, accounting for 42% of those deaths in 2008. Injury is the second leading contributor to the burden of disease in the Western Cape, contributing nearly 20% to the overall burden and claiming approximately 600 lives each month. Among non-fatal injuries, interpersonal violence accounts for more than half of all injuries presenting to facilities in the state sector across all levels of care. But we know that violence is preventable, and this obviously informs our integrated policy framework, whose objectives are as follows. Firstly, what we sought to do was to enhance collaboration between the various sectors within government, principally our health department with criminal justice, but also we realized that the departments of education and social development have a very critical role to play in addressing more holistically the kind of longer term interventions that are needed to prevent violence. So we wanted to institutionalize an intersectoral framework that sustains and supports a multi-dimensional violence prevention strategies over a long-term period. And we would do this by balancing programmatic and policy interventions likely to reduce violence in the short term, and that focuses principally on reducing access to alcohol, but also having a strategy for substance abuse in place, as well as interventions that are more likely to affect long-term changes to the social environment, as well as to societal norms that support violence. And I'll get into those in greater detail in due course, but that would include things like focusing on early childhood development and positive parenting. A critical objective is to adopt an intervention approach that's driven by an accessible evidence-based and also reliable injury surveillance data. And lastly, to provide a framework for programs and interventions that can affect behavior change by incentivizing behaviors that prevent violence and disincentivizing behaviors that promote violence. We've got a partnership in place with an organization called Ideas 42, which is a think tank based in New York, aligned to Harvard University, that's helping us look at behavior change in key areas, and one of them is in the field of violence in younger. So, we looked at the various risk factors for violence in the second part of the violence prevention policy, sort of setting up the context for the strategies that we seek to adopt. And this is based on the work of Richard Matsopoulos and some of his colleagues, who identified 4 main risk factors for violence. And those include biological, behavioral, sociocultural, and structural factors. Biological risk factors, as many of us will know, young males are particularly more likely to be perpetrators and victims of violence. Mental and physical impairment is closely linked as a biological risk factor to violence, as is abuse and neglect in childhood, which affects brain development. It negatively influences cognitive, psychological, and social adjustment, and that sets up a whole lot of problems later in life. Behavioral risk factors would include hyperactivity, impulsiveness, attention problems experienced in early childhood, which will be exacerbated and intensify over time, but also very critically for the purposes of this policy framework, alcohol and substance abuse have been identified by us as key behavioral risk factors for violence. And that figure there of between 27 and 40% of intentional injuries being related to the use of alcohol, I think comes from a study by Charles Parry. Thirdly, sociocultural factors. These would include families with a large number of children, mothers having children at a very young age, low levels of family cohesion, single-parent households, low socioeconomic status, abusive parental behavior, including harsh physical punishment and parental conflict. All of these things are socio-cultural risk factors linked to violence. And then finally, the broader kind of environmental issues, the structural factors, which include inequality, urbanization, and migration, all exacerbating factors. The violence prevention strategies upon which we've chosen to focus are drawn quite heavily, or lean quite heavily, on the World Health Organization, which recommends these key strategies. Firstly, developing safe, stable, and nurturing relationships between children and their parents or caregivers, developing life skills, for example, social, emotional, and behavioral competencies in children and adolescents. Thirdly, reducing the availability and harmful use of alcohol. Fourthly, reducing access to lethal means, including guns, knives, and pesticides. And then the longer-term social norms interventions, promoting gender equality to prevent violence against women, changing cultural and social norms that support violence, and then finally identifying victims and providing care and support programs. That just reiterates the need for the intersectoral approach that balances the short-term interventions, focusing primarily on access to alcohol, with the longer-term interventions that look at the more complex societal causes of violence. So, just to touch on a few of the initiatives, and some of my colleagues will speak about these in greater depth, that the province has already begun implementing to address violence. The Western Cape Liquor Act was passed in 2009, and that focuses on reducing trading hours, reducing the availability and access to alcohol, and also moving towards what we call a high street model, which clusters premises where you can consume alcohol in safer spaces. And this draws on some of the work too that's been done by the Violence Prevention Through Urban Upgrading project, which we'll hear about in the next session. We're also engaged in what we call a selected high-risk area intervention in 5 areas that we've identified, which include Khayelitsha in Younger, Elsie's River, Hart Bay, and Kaimandi. And I'm going to leave Tracey to speak more about that because I'm under some time constraints here. The second major focus is the strategy looking at developing safe, stable, and nurturing relationships between children and parents and their caregivers. and this would include home visiting programs and parenting education programs. We know about Triple P in the United States, but it was very interesting to learn at the panel session yesterday of some positive parenting programs that are being piloted here in Khayelitsha. The third main area looks at developing life skills in children and adolescents. The evidence is very clear that life skills acquired in social development programs aimed at building social, emotional, and behavioral competencies can prevent youth violence. Life skills programs that target children in life can prevent aggression, reduce involvement in violence, improve social skills, boost educational achievement, and improve job prospects. And we have various initiatives underway in province aimed at doing these things, driven by both our departments of social development and cultural affairs and sport. We have something called the MOD program, the Mass Opportunity Participation and Development Centres. There are about 180 of them. They provide an integrated after-schools program which runs between 2 o'clock and 6 o'clock in the afternoon and gives children the opportunity to engage in sporting, artistic and cultural activities, provides a sort of a safe space to do that and keeps kids off the street after school hours. We also adopted an early childhood development strategy last year, and we're in the process of finalizing a youth development strategy. Finally, the strategy that focuses on promoting gender equality and changing cultural and social norms that support violence. We're interested in looking further at school-based programs that can address gender norms and attitudes before they become very deeply ingrained in children and youth. And then Noah will speak more about some of the work that's being done by the Safety Lab on programs targeting youth violence and education through edutainment, which, as we know, has a whole range of positive impacts, including reducing intimate partner violence later in life. So, in conclusion, what I would like to stress is that the successful implementation of all these various strategies, both short-term and long-term, and their associated interventions, and those interventions haven't all been worked out, which is why we are so interested to participate in this colloquium to find out about best practices from around the world, evidence-based interventions that could inform public policy. But what is critical is to emphasize that it requires the cooperation of role players in the public health and the criminal justice sector in the first instance, but also in social development and education and the citizenry, civil society more broadly in a whole of society approach to violence prevention. Thanks very much.
Thanks so much, Michael. That was 15 minutes.
Thank you very much for the opportunity to come and speak to you today. And as Michael said, we're quite excited about this initiative to hear what you all have to say about this important area. I think in terms of the key challenge around violence prevention in particular, as many of you I'm sure understand, is the complexity of this. It's a multidimensional problem. It requires multiple prevention strategies, and from the health department's point of view, often these strategies are outside of the health department. It requires some kind of long-term interventions and some short-term interventions. I mean, we know around the legislation of around firearms and what that did in terms of mortality rates related to injuries. And a lot of these interventions are at various ecological levels, as Michael alluded to. And as the health department in particular, we largely deal with biological factors. You get sick, we give you pills. So you hurt yourself, we sew you up. So historically, that has been our strength as a health department. And in terms of our constitutional mandate, we are mandated to provide health services. And really, there is no silver bullet. And in terms of the role of the Department of Health, Michael alluded to the fact that really injuries are a huge burden for us in our trauma units, particularly in certain areas that I'll speak to in a moment. So as the Health Department, because I think we find ourselves as the receivers of the burden of injuries and violence in terms of violence, road traffic injuries, etc. I think, you know, it's a curse and both an opportunity. You know, it's a burden on our services, but then it also provides us the opportunity to be a hub where we can collect information, because oftentimes people will get injured, but you know, they will seek health services, but they may not necessarily go and report to the police. So we've seen that as an opportunity from a surveillance point of view and from a monitoring and evaluation point of view around how we could use the information that we have both within our trauma units and our forensic pathology services around measuring effectiveness. And also around advocacy, how do we use this information to advocate to others? As I said, a lot of the violence prevention interventions are outside of the health department. And working with stakeholders around how we could design and test evidence-based interventions. But obviously, as the health services, we also need to provide health services that go beyond just the treatment part, that also speak to prevention. One of the things that we did that emanates from the Western Cape Burden of Disease Reduction Project was this very complicated Western Cape mortality surveillance system. All it is really is we use data that comes from Home Affairs. We take copies of death notification forms from Home Affairs, together with data from the mortuaries, the deaths that are due to injuries in particular. And we put it all together, and we have a local mortality surveillance system, and we have a database of mortality. And what we're able to do with that information, we're able to profile our burden of disease in the province. You'll see particularly around injuries, you've got this huge burden. I mean, we speak of a quadruple burden of disease that we have in the province, actually in the whole country, where it is around injuries, particularly in young men, which is the green over there. That blue over there, it's chronic diseases of lifestyles like diabetes, etc. This orange over here is your infectious diseases, particularly HIV and TB, and then you've got childhood diseases over there. So with that information, we are able, I won't go into detail, but we're able to plot to the level of the sub-district at the moment, not much lower, about the profile of the burden of disease. What we've also realized is that the profile of injuries in particular is concentrated in particular areas. We discovered that if you look at these 5 areas over here, this is data from 2011, Khayelitsha, Gugulethu, Nyanga, Kraaifontein, Philippi. We found that these areas contributed to about 50% of alcohol-related violence. And this is stats from the police data that was released recently around murder in 2013. You'll see the top 5 police precincts are very much similar to those areas. So this then brought this notion of identifying these high-risk areas that we need to focus on. The second thing we realize is that, and I think Andrew Nicol and his team also alluded to this yesterday, is that when we look at mortality, is really just the tip of the iceberg. We're looking at those that are dying, but there's a huge burden of those that are ending up in trauma units that get injured but don't die. And what's important about that profile is that it's slightly different, and I'm going to talk here around gender differences, is that you'll see from the mortality stats over here, about 14% of the burden is from injuries. And if we look at morbidity,